Good evening, everybody. We thank you for joining us for a Hurley Healthy Living series. We do these once a month with different topics. Most of the time they're held here. So however you found out about us for tonight's event, we always advertise on the same places as well. I still have some other people that are probably going to join, but for the sake of your time, we're going to go ahead and get started. I would like to introduce to you to Dr. Alkotob, cardiologist with Hurley, and he's going to give you lots of good information tonight. The paperwork that I handed you, there is a form you can fill out, and you can hand it to me at the end of the evening. If you'd like somebody from Dr. Alkotob's office to contact you to make an appointment, we'd be happy to do that. And we thank you for coming.
Hello.
Hello.
Thank you all for being here. This is beautiful because it's a small group of people, and we can be as interactive as you guys would like this to be. So I recently lectured at a 150-year-old university, and I told them, you know, there's a lot of letters after my name, but if there's something I value the most is to be able to teach. And whether I'm teaching, you know, medical students or the public, it's equally important to me, and I'm proud of it. So I got to give you a quick background about myself. I'm currently the chief of cardiology at Hurley Medical Center and the director of the cath lab. I started my journey over at Cleveland Clinic many moons ago. I'm not going to tell you how long because then you'll figure out how old I am. And after Cleveland Clinic, I went to University of Connecticut to do further training in cardiology. And after University of Connecticut, I went to Boston University. So people ask me, how'd you end up here? And it's a woman. It always is, you know, right? What else?
Right.
And no, it's the weather. Actually, I love Michigan weather, and you know, that's why I'm here. So long story short, we are here to talk about, you know, the heart, right? And I got to draw your interest in thinking, you know, what is the heart really? How do we think? How do we address the heart in our culture, in our literature, in our life? I mean, to some people, it's just a hollow, you know, muscular organ, you know, located behind your sternum. That's where your, you know, anatomical description of it. To some people, it's the center of feelings and intuition. And I don't know why we say that, but to some it's just a variety meat. And to most of us, it's the center of our enthusiasm, emotions, intentions, all of the above. So I have a friend of mine who is a neurologist, and I tell him that we're only dead when the heart stops, and the brain only follows what the heart does, right? He's not as important. That's just as simple as it is. You might see him on one of these talks. Please remind him that he's not as important. All right. So it's the essential, most vital part, idea or experience of life. So let's take us back a little bit. Let's describe how important the heart is with a story. And, you know, we're going to take this 65-year-old man. He was known to have high blood pressure, high cholesterol, and he went on playing golf one of those nights, and he started feeling some chest pain, burning in the chest. You've heard that story before, probably. He thought he ate a lot of onions in his hamburger. He took some milk and mag. Another time at night, he continued to feel uncomfortable. Now, I'm describing things exactly how they happened, all right? But I'm going to bring you to how important, because a lot of people feel those symptoms, and then they just, you know, brush them as if they're nothing. Well, about 2:30 a.m., the pain got a lot worse, and it woke him up from sleep. And got to a hospital, an EKG was done. They confirmed that he was having an acute heart attack. Now it's been several hours, but he got some morphine for his pain. And for the next 9 hours, his doctors did nothing. It would help if I told you who this guy is and when this story took place, because it was a little bit a while ago. This was, in fact, the 34th president of the United States. Now, after scrambling to see what happened, they called a very famous cardiologist at the time, whose name was Paul Dudley White, to manage him. And Paul Dudley White has then founded the American College of Cardiology. So a little bit of history to see how important that is. That incident was extremely important, because how did we treat that heart disease? They gave him blood thinners, and they committed him to bed rest for 7 weeks. And if you look in history, actually the stock market almost crashed at that time. There was a lot of uncertainty of what's going to happen. And what happened to him was that he had a clogged artery. So if you look at the heart is supplied with fuel or oxygen through 3 arteries, one that goes to the front, one that goes to the side, and one that goes to the bottom. And when a plaque buildup in that coronary and the artery is ultimately blocked, it's supplying nutrition to this part of the heart. And if you took that, God forbid, post-mortem, to look at the heart muscle and cut it in half, you will see that this is what we call an infarction. It's dead muscle. And if you think that this muscle is going to contract to get the blood out, this part is not going to work. And that's when the heart fails, and that's when some people fall into congestive heart failure. So it's not just a matter of living only, it's a matter of living well. So with that, what is heart disease? And there's a big variety of those that we will come about to describe it, but why is it important? Well, 1 in 5 deaths in the United States is due to heart disease. It's the leading cause of death globally, but most importantly because it's often preventable. And that's the key word. And I'd like to say a very important note. Consequences of heart disease are often preventable at any age. It's never too late to take charge of one's own health and prevent an upcoming problem. Because like I said, it's not a matter of living, it's a matter of also living well. So, if you look at the human body, the heart is in the middle, but it is attached to all these blood vessels that go to every single part of your heart. That's why we call it cardiovascular disease. What affects the arteries in your heart affects the arteries in your legs, affects the arteries that go to your kidneys, affects the arteries that go to your brain, affects the arteries that go to your liver, etc. There's an impact everywhere. So the variety of heart disease, yes, the most famous one is coronary artery disease. These are the blocked arteries in your heart. But there's also congestive heart failure, when the heart muscle gets weak, or when the heart muscle does not relax as well. There is also abnormal heart rhythms. In fact, most of our patients come to us a lot of the times with abnormal heart rhythms, and those abnormal heart rhythms can also cause stroke. So, peripheral arterial disease, patients who can't walk long enough, don't have enough blood supply to their legs, or don't have enough venous return from their legs. This is also part of cardiovascular disease. Carotid disease, the arteries that go to the brain. So what I'm highlighting with this introduction is the importance. These are some of those statistics. I'm just giving you numbers. It's 31% of all global deaths. And cardiovascular disease is about more than 75% in low and middle income countries. So I have the fortune of traveling around the world to do cardiac catheterizations and interventions, not just here. So I've seen it in very modern countries. I've seen it in very underdeveloped countries. I've seen it in developed countries. I've done cardiac catheterizations at great institutions like Hurley, at tertiary care centers like Henry Ford and Cleveland Clinic, and I've done it in a basement in a third world country. And what you can see, the difference is age. We're lucky here to live longer and treat this disease when we are much older, whilst in other countries, a lot of the time the patients are in their early 40s and their 30s sometimes. Smoking is a pandemic that we've done better with here, but not around the world. So, like I described the former president, I'm telling you the symptoms can vary. A lot of you have heard about the book, men are from Mars, women are from Venus. So yeah, men read the book. They come with chest pain, going to your arm, it's a heart attack. Woman, well, I just felt a little tired. Something was weird about my right side of my jaw. These are not things that I'm imagining. These are things that I've heard over the years. Counter argument, it's not always your heart. It's just this is a call for us to be vigilant, not a call for us to be afraid. And the risk factors that we need to worry about are the ones that we all know but we all ignore. And those are high blood pressure. You can't imagine how many patients I see who are getting treatment for high blood pressure, and I'll ask them, when was the last time you've checked your blood pressure? The answer is, I don't. Only when I go see the doctor. Well, how often do you go see the doctor? Once a year. So how do you know that your blood pressure is good? And they come to the office and their blood pressure is through the roof. They're like, but I take my medicine, everything is perfectly fine. Everything is not perfectly fine. And unfortunately, the first warning sign about that could be a stroke. So as bothersome as it is to go see that doctor and listen to them yapping, it is not nearly as bothersome as having a stroke. Looking at controlling your diabetes, most importantly, actually nowadays, controlling your cholesterol. And there's a difference between controlling the cholesterol for someone who has had heart disease versus someone who hasn't. And there are rules and there are trials, clinical evidence, medical literature to guide us to where we go. What's important is who's treating that for you, because one size does not fit all. You cannot get enough opinion from a physician who tells you, you only have to do it this way. Well, if it's not working for that patient, then we have to look for another way, because the goal at the end is to help the patient, not to make a point. Obesity, smoking, physical activity, etc. And there's one that we cannot control. I'm going to take this one back, and that's very, very important. Family history. No matter how advanced we are right now, we haven't done enough, or genetic therapy hasn't made it far enough that we can change, our genetic makeup. And if we are predisposed because of our family history, we are predisposed. That's just a fact. We may be able to delay the inevitable by controlling other risk factors, and I have a lot of families like that. The father had their first heart attack in their mid-30s. We were able to push the son till their mid-50s. But what's more important, that is, there's more to come. And in fact, there are ways to even improve our genetic makeup that I won't be getting in here today, but I'm telling you, the future for that is good. Okay, so we started with high blood pressure. Why is it important to see a doctor? Because those guidelines have changed over the years, from when I was a medical student to when I was in residency to when I was in training to even more recently. We used to say, I'm just bringing this to enlighten, the group, that 140/90 is a good blood pressure. Then the guidelines changed. JNC7 was 120/80. Then it went up and said JNC8, no, 140/90. Then it says if you're over 60, 150/90. And now we're back to ACC guidelines, back to the 120/80. The thing is, that's where that discussion with your physician has to be. That's the majority of people can reach the goal that they need with a little bit of finessing of the regimen. Yeah, is right. That need not to be in anybody's diet. Maybe once a month, twice a month is okay. Maybe if you went for a long walk afterwards, maybe if you enjoyed like 1/3 of that and not the whole thing. Plus, where it came from also matters, to be honest with you. What, oil it was fried in matters. What kind of meat matters. The point is, eat as clean as you are able to. And, I'm going to assume the majority of you are health conscious. That's why you're here. So this may not, pertain to you. I'm going to tell you this. This is very interesting. I've learned this a long time ago. This is an algorithm for healthy living. So pay attention. Okay, ready? Yeah. Ready. Okay. See, the Japanese, they eat very little fat, but they suffer fewer heart attacks than the British or the Americans. Okay? On the other hand, the French, they eat a lot of fat, yet they still suffer less heart attacks than the British or the Americans. The Japanese, they drink very little red wine and they suffer fewer heart attacks than the British or the Americans. The Italians, they drink generous amounts of red wine and they suffer fewer heart attacks than the British or the American. Eat and drink whatever you want. If you speak English, it is going to kill you. I didn't make this stuff up, by the way. This actually came from a very good reference, but 20 years ago. All right. Wow. That's just to give a break. Now there's good news. You being here, you listening, the world listening, lowering the cholesterol, improving the blood pressure, the adjusted rate of deaths from heart attacks have gone down dramatically over the years, and it continues to go down. And this is evidenced by the fact that we are living longer. It's getting down because we have emergency programs to treat heart attacks. It's getting down because we are controlling the cholesterol, we are controlling the blood pressure, and people are becoming more health conscious. We do have a problem that remains, which is the 21st century. We need a car to go everywhere. We don't get off our chairs. We don't have time to exercise. We are overwhelmed with our lifestyle. And if you look at Michigan, it is in the top for obesity and sedentary lifestyle. And we can't, by the way, blame it just on the weather. I mean, look at Texas. It's right up there with us. So we can't just blame it on the weather. We need a change of mindset. So when patients come to see me and I ask them, are you active? They say, yes. I say, do you exercise? No. So how are you active? Well, I'm active around the house. Does that constitute enough activity? The answer is I don't know. It may for some people. But it would be much nicer if we take part of our day and specifically devote that to physical activity that is a conscious physical activity. And I hear a lot of people complain about that because they say, well, I'm not able to run on the treadmill or do that. And you know what? Walking is an incredible exercise. And if you can't walk fast, just walk longer. And if you can't walk longer, then walk and rest. And after you rest, get up and walk again. And if you can't do it the whole time, then do it some of the time. And just increase it gradually. And if you ask me, well, over how much? A month? You have a lifetime. If you're doing it with a goal in mind, I don't care if it takes you 10 years to move from step 1 to step 5, but you at least are working on it. Now, why is that important? See, America, we have very strict rules about how we do our clinical trials, but the rest of the world doesn't. So years ago, there was a study done in Germany where people looked at blockages in the main artery, the one that they call the widowmaker, right? But it wasn't proximal, it was in the mid-left interdescending artery, and they randomized those people to exercise over a bike or to get a stent. And they looked at their mortality, how many of them died in 6 months to a year. Guess who died more? The ones that got the stent. Because the others were carefully monitored, they exercised, and there was improvement in their overall health. So you get the picture. What's happening to the arteries? It's as simple as that. It starts out beautiful and healthy this way, then for genetic and obesity and sedentary lifestyle and high cholesterol, the fat starts building up in the intima of the artery, which is the innermost layer of the artery. The artery has 3 layers. And the soft, smooth muscle inside, and then it breaks up and we get a clot that closes the artery or reduces the blood supply. So what have we learned over the years? We've learned about that and less about our physical activity and exercise and diet. But unfortunately, and I can say this because I'm a free man, with pharma, they keep making clinical trials that tell you more medications are better for you. I would argue that if you're not going to take the approach of diet and exercise, yes, then more medicines are more important for you. And it depends on the disease process. And it depends on the communication with the patient to help them understand why they are taking those medications. It's very, very important. And I'm going to add one more thing to that. By show of hands, how often do you think when I ask a patient what medication they take, do they know exactly what they take? I'm going to 10%, 5%. 90% of patients do not know what they're taking. And you know what their answer to me is? Isn't it written there in the record? I take the red one, or the blue one, or the yellow one. You may be guilty of that yourselves. I'm just telling you, but I'm going to here give you one message. Guess who cares about you the most? You. I have 20 minutes with you, half an hour with you, and then when you leave, I got to pay attention to the next person, right? So why would I know your medications better than you? Not only you should know what you're taking, you should know how much you're taking, how often you take it, and why you are taking it, and for how long do you plan to continue to take it. And it shouldn't be that hard. And I'm not being belligerent by saying that. You are important to you. You need to know what you are taking. So what fits your busy schedule? Exercising 1 hour a day or dead 24 hours a day? Yeah. Better yet, with this new drug, the cholesterol forms outside the body. It will not be able to clog the arteries. We don't have that. My doctor told me to avoid any unnecessary stress. I did not open his bill. All right, so what's the bottom line? Why are we here today? Well, you got to ask yourself those questions. Am I diabetic? Have I been checked for that? Because that's important. And it's important not because it's cumbersome, because we can treat it. You can get better. Those tools continue to increase every day. In fact, there's an explosion in medications for diabetes, something that I haven't seen with any other disease process in the past 5 to 10 years. What are my risk factors for heart disease? Have I been checked, or should I be checked for those? And is my physician addressing everything that he should address to reduce my risk? Now, I don't want this on tape, but unfortunately, I have to say this. I see a lot of primary care doctors who are not addressing the problem. You're just a number. You come in, you come out. You know everything is fine. Same old. Goodbye. And then when they come to me and I say, well, let's check your cholesterol. Well, I did my blood work with my doctor. Okay. Did they check your cholesterol? I don't know. Did you ask them what the numbers are? Why would I know what the numbers are? So forth and so on. Patients, the public, have the impression that all our records and electronic medical records and paper records are somewhat connected, and that magically the physician should open your chart and find all these things. They are not connected. I can tell you that much. The best way to connect them is yourself, to be honest with you. Okay, so know your numbers. You need to know what is a good cholesterol. You need to know what's a good cholesterol and what's a bad cholesterol. And those numbers continue to change, and we continue to push the envelope, because the more we lower them, it appears to be the less patients die. And that's a drastic change, by the way. So I tell my students, my residents, my medical students, there is no dogma in, this is old, so these numbers are not correct. I'm going to tell you right now. There's no dogma in medicine. What's correct today may be incorrect tomorrow. We just have to follow the clinical evidence and the research that's coming out. But yes, in general, they tell you, your total cholesterol should be under 200. Well, what if it's 220, but it's because your good cholesterol is very high? My mother-in-law is like that. She has heart disease. She has, bad valves. Her arteries are beautiful. Her good cholesterol is like 90. She's going to live forever if that was the only problem. But unfortunately, it's not. So you don't only need to know the crude numbers, you need to know what's the bad cholesterol, and you need to know what is your good cholesterol. And if that is still a case, I like this schematic here. It's going to burn through your money, and it's definitely going to burn through your artery for sure. So if somebody is smoking, it's the common sense to stop. It's the common sense to get some good sleep. Exercise your brain. What to eat, there's a million diet I can tell you, but eat better is better. And have a positive attitude, because I've had a few slides about that actually. I'll tell you about one in a second. But most importantly, be proactive in your healthcare and remember that it's never too late. You're still here for a reason. So if you're still here, we treat people to achieve one of two goals: live longer or feel better. So if we can't achieve both, then there's no point of going to a doctor. When I did my interventional fellowship, it was in Boston. So you all know the Boston accent. So you ride in your car, right? So this 90-year-old man went to his doctor. The doctor gave him advice, and the next week, month later, he saw him in the street. The physician saw the patient in the street with a young lady right by his arm. And he's like, "Wow, you look great. You look like you're doing really good." He said, "Doc, I did what you told me. You said, get a hot mama and be cheerful." It's like, "That's not what I told you." I said, "You have a hot murmur. Be careful." Hey, the guy had a positive attitude. You got to give him that, So, again, this talk is to give hope, not to scare you of what's to come. It is to encourage you to follow prevention. Prevention leads to education and intervention to get treatment and care. I'm very proud to be working at Hurley. I started, 16 years ago in this community. I used to go to all three hospitals and then decided that Hurley's my home. We have gone through a lot of changes. We used to do, only emergencies and acute heart attacks, to the point where we now do elective angioplasties and we do EP procedures, pretty much everything that needs to be done, and attached ourselves to tertiary care centers through our, connections through the hospital and personal connections to where we can get the complete care that is needed. So it's definitely my home, and I'm proud of it that we can provide all the care that we need, and that includes also the cardiac rehab, which is very, very important. In Hawaii, Medicare pays for intensive cardiac rehab just based on risk factors. But in 90% of the nation otherwise, you only get to go to cardiac rehab after you have a heart attack or congestive heart failure. Isn't that silly?
Yes.
You would think it'd be the other way. Like, let me go to cardiac rehab, cost healthcare just this much money and learn habits that will help me avoid all these problems. But unfortunately, it's being done in the opposite manner. Okay. So how can you help? Get regular health screening, educate your family, educate yourself, support health initiatives, and advocate for better food and healthcare access. Thank you very much. I hope this was helpful. I'm going to answer some of your written questions, and I'm happy to take more as well. Thank you. All right, so before I go to this, do you guys have any questions from the audience?
Do you support the use of any supplements?
That's a great question. So people who take supplements are usually very health conscious and very pharma suspicious. And I do support people taking supplements, but I can't tell them how it's going to help them, because those supplements have not been scrutinized to the degree of long medical literature to tell you whether they work or not. I do not support it when you have a serious problem that requires a definite, medication. And, I think that's as far as anybody can take it.
Okay.
To answer the question. Yeah. Yes, ma'am.
So I've done medical maintenance, and I've gone in and had a CTA with calcium score.
Mm-hmm. So that's not a CTA, it's CT with calcium score.
Okay.
A stands for angio, which means you've also got the anatomy looked at.
Okay, yeah, no.
Yeah.
So they're telling me that I have 50 here, 25, 50, 70.
Mm.
Two cardiologists have told me that that is not an exact science, that test, and that you could have 40 down here or 50 down here.
Yeah.
So I tried to have the next test
Yeah.
with the dye,
And?
I felt like my body was gonna blow up in flames
Uh-oh.
and they couldn't get my heart rate down
Mm-hmm.
far enough. Because I'm usually at 84.
Are you ready for my answer?
Yeah,
Okay, wonderful. So first we had radio, then we had a TV, then we had an iPad, then we had YouTube. All these are tools, and they're amazing tools if you know how to use them. So to just educate the public, she's talking about two different tests. The first one is called a calcium score. So basically, the more you have buildup of cholesterol in your arteries, it ultimately can transform into a hardening that is displayed in a manner of calcium. So if you take a CAT scan, CT scan, and do one spin around the body, cheap test, about $100, it can tell you how much calcium you have in your arteries. It can tell you where they are, but it cannot tell you if they're producing a blockage or not, which means that calcium could be on the inside, but it also could be on the outside of the artery. But studies have shown that the more calcium you have a higher risk of having a heart attack in the next 5 or 10 years. It follows a bell curve. If you've studied statistics when you were young, most people fall under the bell curve, but some will be on this side and some will be on that side. It's a warning sign that you might have an event. In my practice, the treatment to that, if you don't have symptoms and you're an active person, is not to do the coronary CTA, which is the next test I'm going to tell you about, but rather to manage the risk factors more aggressively. If my goal for cholesterol was there, let me bring it down to here. If I was doing, half an hour every 3 days, let me do half an hour every day of exercise. That would be my intervention. The other test is a coronary CT angiogram, which is like doing a heart catheterization, looking at the arteries directly, but only with a CAT scan. The problem is, again, it's not an exact science, because if you have calcium, calcium shines through, and it might fool you into thinking that the blockage is more than what it is. I think there's a place, and a great place, for all these tools, but they have to be used in the right manner. And unfortunately, in my opinion, they've been pushed in the public sector so much that patients are getting them, and it's just making me have more business. People are coming more and more to ask about, well, I had a high calcium score, now what do I do? I encourage you to consult first before you go to the next step. I hope that answers the question. Mm-hmm. Okay. Anybody else? Yes, ma'am.
Can you talk a little bit more about the genetic predispositions that you
Yeah.
had up there?
Yeah. So unfortunately, family history is something that we cannot avoid. And if we have what's called a premature coronary heart disease, a woman less than 55 years of age or a man less than 65 years of age in our first degree family, father, mother, siblings, with a heart attack, then that means you have to take an approach more aggressive than everybody else. And the two ways that you can counteract that, there are studies that have shown that people who exercise more and who are more diet conscious with less animal protein have an increase in something called telomeres. And telomeres are little additives to your DNA. Now, this is, again, not an exact science, but the longer your telomere is, the longer you live. So all these preventive things that we talked about help prolong your telomeres. So you can actually fight your genetics with your lifestyle. Conversely, no medication has shown to do that, literally. Secondly speaking, as the genomic makeup is being more well known, and as we have clinical trials to interfere with that, you may be able at some point in the future to turn a gene on or off. And by turning it on or off, you could reduce the risk. So I see a bright future, but I just don't know how far it is.
So would you call high cholesterol, is that a genetic thing, or is that really more how your family eats?
No, I would say how your family eats is about 20% of it. But 80% of it, unfortunately, is not your fault.
Okay.
And that's why we have to look at it and we have to treat it. And just so you understand this, when we treat cholesterol, all you're doing is you're removing it from the bloodstream so it doesn't get picked up by the arteries. And you're doing that by having your liver scavenge more of it. We call it, the technical term, and that hasn't changed in the past 25 years, you're upregulating the hepatic liver receptors to scavenge the LDL cholesterol, the bad one. Whether you're doing it through statin medications or nowadays through PCSK9 inhibitors or Nexletol, or there's a variety of cholesterol medications at this point, and they all have a role. But yeah, I think 20% is your fault. But 20% is not little.
Right.
And I've already told you that what you eat and exercise is independent from those numbers, meaning it has an independent impact on your heart disease and heart events. Does that make sense?
Mm-hmm.
Yeah.
As far as,
Yes, sir.
aside from family history, what's the food that would be, the worst for cholesterol?
Oh, well, that's highly debatable. I can tell you what is considered the best. So what's considered the best?
Fruit and vegetables.
Now, let me make it more specific. So there are clinical trials. I'm a man of science. I have to answer based on clinical trials. Vegan diet, just straight vegan, has been shown to reduce your events of heart problems. Okay? There are people that take that a step less and they go to pescatarian diet. They'll eat fish and everything else vegan. The Mediterranean diet, but that's pure Mediterranean diet. So you're sourcing all your food clean. You're using olive oil without burning it. You're reducing your total intake of saturated fat. And there are people that go with a paleo diet. Why? Because they'll tell you, well, yes, I'm eating fat and I'm eating meat, but it's all from pure resources. Now, if you ask me, my opinion, if you take all these opinions together, you'll come to one conclusion: less processed. If you're eating less processed food and more well-sourced food, you're probably going to be better off. Not everybody can follow a vegan diet. I did it for 6 months. I thought I was going to lose my mind. Not everybody could just eat fish. But if you are, God forbid, 40 years of age, and I have patients like that, and you already have a lot of blocked arteries, then maybe you should go to that extreme. But I wouldn't give this to the public. I actually have a public servant who has that. He's young and he has blocked arteries, but we've managed him for years now by diet and exercise and actually other medications that helped him lose weight and feel good. But he is very strict about his diet, and he hasn't had an event, thank God. Knock on wood. Yeah.
So are you going to talk about tests next?
I'm not.
Oh, because I was going to ask, I
Yes.
was with my cousin this morning, and she said that she does that life scan
Yeah,
stuff
yeah.
that they do, and then she gives it to her doctor.
Yeah.
And I just wondered what you thought about those.
So one of the
Not to throw them under the bus or anything.
no, it's fine. I mean, listen, more care is better, but the debacle that we have with medicine is that insurance companies put a lot of limitations on what you can do.
Yes.
And then you have these companies that come and they'll tell you, oh, I'm going to look at your carotids and I'm going to look at your to rule out. They're good for what they are. So if your carotids are normal, and if you don't have an aneurysm, hallelujah. But that's all they do, I think.
Right.
I think
yeah.
it is just a couple of tests.
The carotids, the aorta.
The aorta.
And the blood flow.
Yeah, to be honest with you, yes, if you want to get that information and they look fine, but I don't want them to give you a false sense of security when it's meaningless. Because if you go to Medicare guidelines or even science, there's no indication to check one's carotid almost for anything unless there's an event previous to that, or the doctor hears a sound that we call a bruit. Vast majority of those tests come normal. So, like I said before, like the iPad and the TV and the YouTube and the Chat GPT and whatever it is that you'd like to use, it depends on how you're using it. If you're using it for good, then that's fine. I would not throw them under the bus. I think it's relevant information. But would I encourage you to do it? The answer is no.
Okay, that's my inkling.
Yes. Yes, ma'am.
So, I've had 2 or 3 people say to me that Widowmaker,
Yeah.
that, number one, if it gets to 100, you're done. And then said that other veins come out from it to feed your heart when it gets that blocked. Well, I don't understand all of that. I'm just wondering.
It's a fair question.
Okay.
The question that I'm going to ask you is, do you really need to understand that part, that technicality? Because if you were my patient, what I would tell you, are you having chest pain, yes or no? Are you controlling your cholesterol and your blood pressure, yes or no? I'm just asking general questions. And are you active and watching your diet? And if you're going to tell me yes to all these things, I'll say, then stop at that. Stop looking. If I take each and every one of us and I scan them from top to bottom, I'm going to find a lot of things. But you know what? A lot of those things I shouldn't do anything about. I should just leave them alone.
Okay.
Yeah. Although now we have this new test, they're doing this MRI, you know. They scan you top to bottom looking for things. It could save some people, I'm not going to argue, but as a public, you know, for the general public, I don't think it's a great idea. You had a question, sir?
Yeah, if he had an open heart surgery, how often is it before you might have a stroke?
Yeah. I think when you have an open heart surgery, for a bypass surgery, not for a valve, it's a wake-up call and you're resetting the clock. Because now you have all these veins or arteries that bypass the blockages, right? That's what a bypass is. Now you have to worry about them getting blocked again, which takes us back to step one. Let me control my blood pressure. Let me bring my cholesterol to a much better level. Let me bring my activity level to a much better level. I have patients who've had the widowmaker that we fixed, who've had bypass surgery that we fixed, and I've had them for as long as my practice has been in here, for 16 years, and they haven't had any other event. So you're resetting the clock. You know, again, hope over, you know, fear and anxiety. One of the reasons I became a cardiologist, because it's something you could treat, something you could make better.
If your heart is fairly healthy, is it fast walking? You know, if you can get your heart pumping the hardest and the, you know, is that better than just mild walking?
Most definitely, yeah.
Well,
I mean,
you
to
know,
give yourself a
treadmill,
little bit of
just
effort.
You know, does that make it more healthy to
Yeah, so it's,
pumping?
yeah, so in the pure form of it, the answer is yes. When you get your heart rate up, it's like you're training your muscle. It's like you're carrying weights, right? You're making it better. You're making it more efficient. Therefore, the guy who exercises all the time can come and pick, you know, 60-pound box or 100 box, while the guy who doesn't can barely do a 20. The concept is similar. But the problem is when people try to take all or none. Oh, I can't do that, therefore I'm not going to do anything. To that guy, I'll say walk slowly. That's better than not walking.
Sure.
Does that make sense?
Yeah.
And actually, what matters the most when it comes to walking is the duration. How long you're going to do it. So, and I don't, please forgive me if you're retired, but if someone is retired and they tell me, but I don't have any time, and I'm like, what are you talking about? You have a board meeting? Just put them on Zoom and just walk on your treadmill. You have time. You make time. Yeah.
I went to the doctor, he gave me 6 months, I couldn't pay the bill. So
Yeah.
He gave me 6 more months.
That's a good one. I'm going to take that one.
Don't use that.
I'm gonna. Sorry, no patent here. All right. So there's a couple of questions here. What is the average age person has a heart attack? Because my dad died from a heart attack at age 44. Definitely, it should ring, you know, bells, and you should go and bring down your risk factors a lot more than what your father was, in order to not have the same result. Having a family history is not a death sentence, it's just a warning sign. And sometimes those warning signs might help a lot of people who otherwise wouldn't have, you know, taken care of the problem. Another question, is there a way to check my arteries for any blockage? I have experienced fluttering. So remember how we said heart disease comes in a different variety? So fluttering could be abnormal heart rhythm. It doesn't necessarily have to be an expression of a blockage. But to differentiate between the two is important. There's many ways to check your arteries. You can do in my opinion, still the best way is to do what's called a functional study, get a stress test. There are people that want to take matters into their own hands and want to do the coronary CTA and want to pay $800 or something like that to get the test done, the one that you said they couldn't get your heart rate down to. You have to have a low heart rate for the test to be accurate. But then they get information they're not sure what to do with. There's a 60% blockage. What do I do? Why, are you having symptoms? No. Forget about it. I can't forget about it. Now I know that it's there.
It's true. Yeah.
So if you had a 60% blockage, and maybe I should know this, but is there a way like to reduce that, or is it really just you're managing it so it doesn't go to 70?
That's a great question, and it's a debatable answer. There are studies that show, there's a study called the Jupiter trial, which studied in the past a medication called rosuvastatin, which is Crestor. And it was an observational trial. It was not a double-blinded trial. So the results are always iffy when it's observational. Mm-hmm. But we checked the arteries on the inside with a machine called IVUS, intravascular ultrasound. So we put the ultrasound inside the artery and we measured the plaque. Mm-hmm. And then we gave them very high dose of rosuvastatin. And we lowered their cholesterol to the bottom. And then we checked in 6 months and the plaque was smaller. So plaque regression is possible. Also, the studies that were done in the late 80s, early 90s on the vegan diet suggested that you might have regression of plaque if you do a vegan diet. I don't believe it, but it's a possibility. So yes, there is a possibility to have regression in the plaque. And I have seen it. I've seen patients who have done the arteries and we've controlled their cholesterol, and like a couple of years later, we redid their heart cath and it looked better. We call that positive remodeling.
So what does the medicine actually do? Does it like slough off a little bit every once in a while?
Yeah, so the human body is a work of art. And what we know about it is far less than what we think we know. Mm-hmm. So positive remodeling means that the lumen of the artery grew bigger. Now, did it grow bigger because of what you said, less cholesterol in the plaque? Or did the artery get bigger and now the plaque is not impacting the lumen? I don't know, and nobody knows. But believe it or not, what's more important than that, what we do know, that's why it's so interesting that we always look for the complicated answers when the easy ones are right in front of us. Eat better, walk more, just see your doctor every 6 months, control these numbers, and you'll be fine. Stop looking. You do not need to know every possible thing in your arteries. Knowing that is just a waste of time because it does not correlate to what's going to happen. I'll give you one more. I am an interventional cardiologist, okay? I've done this all my life. So my job is to put stents in people. But I am one of the lowest people to put stents in people because there is no evidence that putting a stent in a blockage that is not a proximal LAD, that is not causing symptoms that will make any difference in your life, no matter how bad that blockage was. There's no evidence to that. Mm-hmm. While there is clear evidence that if you did all these three things that I talked about, you will fare better. So why would I go to the stent when I know there's no evidence that's going to help you? And I could help you by other ways. If you need it, it's a great thing. It's life-saving. But if you're not having symptoms or impact of that blockage, then it really isn't, and it's misused.
So one last question.
That's what we're here for.
I'm sorry, but I have high cholesterol runs in my family. From
Yes,
my
ma'am.
dad's mom down through to my kids, and they're both pretty active, hiking, soccer, stuff like that. And my son he's 34, and he just got his first real blood workup and everything, and so his cholesterol's high. He won't tell me how high. But his doctor wants to do that scan to see if there's calcium around his heart. Is that, he's not having any symptoms or anything?
So there's a reason for that.
Okay.
And I'm assuming that that's the reason. So we go by numbers, and those numbers are brought in from population studies. So your son, who's very young, if his bad LDL cholesterol is 190 or higher, then it is recommended that he gets treated for that regardless of anything else. Okay. Because the expectation is if that number stays where it is, over the years he will most definitely develop blockages.
Okay.
So you treat it early, you save him. What if the number is a little less than 190, but also still very high? Like let's say it's 180. Now what do I do? Well, the calcium score comes in, the American College of Cardiology in 2025 states, which remember what I told you, what's true today may not be true
Right.
in a year. But currently it says, if you have a calcium score of over 100 and your LDL cholesterol was wishy-washy, then you should take medicine. But if it's 0, then you don't have to.
Okay.
Now, what does that tell you? Take me back to my first statement. One size does not fit all.
Right.
Why is this guy or that guy, imaginable guy, has an LDL cholesterol of 110, had a major heart attack, while the guy who had 170 didn't? Because there are other factors. And what we're doing is we are adjusting the factors that we know today.
And you can only give us guidelines because every person is unique.
Is different, yeah. But then when you sit with the doctor and talk, this is what's also called shared decision making. Then you know what you're risking, by taking the medicine and what you're saving, and vice versa. I have patients who say, I don't want to take a medication. You know what? I don't have a problem with that. That is their choice. I've done my job. I offered them the advice, I offered them the evidence, and then they can do with it whatever they like. Because that's also very important, to be a decision that they make, that they're part of. The worst thing is when they tell me, I don't know why I'm taking this medicine. You guys think this is, imaginary. It really isn't. Most patients don't know what they're taking or why they're taking or what they're taking, for that matter. Okay. I think we've overstayed our stay, but I'm going to just answer those real quickly. How can you test for plaque buildup in existing stent? My answer is you don't have to. Do a stress test. The American College of Cardiology says if you had a stent, then in 2 years you should have a stress test. If you're symptomatic and having chest pain, then different test needs to be done. How harmful are cigars to your heart? Just as bad as smoking. Cigarettes, no difference at all. Don't do it. Just don't do it. It's nasty. It doesn't need to be done. How long does it take for the heart to heal after surgery? The human body is incredible. And if you had open heart surgery, in 1 month, I tell patients who have open heart surgery, every day is going to be that much better than the other. It's an exponential improvement. Yeah, I think these are the questions that I had. All right, yes?
Is red wine good for our hearts?
Order it up, Cindy.
George Burns.
So listen to this. So what is, I don't think you should film this, but I'm going to say it anyway. What is the #1 beverage in the world in the 1960s? It's pop.
Coke, I was going to say.
It's pop.
Yeah.
Any kind of pop.
Yeah.
What is the #1 beverage in the universe now? It's coffee. Coffee. Coffee is #1. And there are many clinical trials now that show that coffee is good for your heart. Guess what the American College of Cardiology said a few years ago? That 2 drinks of red wine are good for your heart. They said that, right? Because it increases your good cholesterol. And this was publicized everywhere. About 4 years ago, the American College of Cardiology changed its stance. And it says that the safest amount of alcohol to your heart is 0. Now guess how much publication was behind that? 0. No one wants to hear it. Everybody wants to hear what they said before. And remember, I told you what's true today may not be true tomorrow. Currently, I would not be honest if I told you that drinking red wine is good for you. Yeah. Maybe you should drink grapefruit. That may be good for you. Unless you're taking a statin, then you have to be careful. It's a long story. All right. And it's a story, and the story does not end here, because the story of the heart is a very important story, and it's going to have many chapters to come. I appreciate you coming and listening to me. Thank you guys all very much.
Thank you.